Look at the schedule. Here we are on 214. We'll get through a lot of this tonight and have probably a short lecture tonight, probably 2 hours, and then 2 hours next week. And we'll be done, you guys. So
Thank God.
I can hear the chorus of sorrow, weeping of tears, and all that. But I do want to remind you, and I'll remind you again next week, we get done early. That's great. But that means you're going to have plenty of time to do this student-directed learning exercise that you'll be responsible for working on when I come and we work on the TBL. So keep this in mind. Go back and look at your syllabus. We will need to do this, or the higher-ups are going to be after me, you guys. I need to do this. So okay, but last week we got into the handout on protein synthesis inhibition. Antibiotics that inhibit protein synthesis. And the aminoglycosides were the first group that I looked at. They are distinct from the other protein synthesis inhibitors because the aminoglycosides, are cytal. When we look at usually when we take a protein synthesis inhibitor, it's bacteriostatic. So the aminoglycosides are that exception. So beta-lactams are cytal, aminoglycosides are cytal. The first group I want to look at is the tetracyclines, and they have several different R groups. It's kind of a little hideous. But what we can do is divide these up. And for tetracycline through methacycline, these are the old, and the doxycycline and the minocycline, I can't call them new. I'll say they're newer. But right off the bat, I want you to be aware, the main tetracycline that gets used is doxycycline. It's the big one. It's by far used more than any of the other tetracyclines that are listed here. So you'll see it so often that you'll think it's kind of in its own class, but it's not. It's a tetracycline. And part of what we see as a difference here is that the older ones have a lot of renal excretion. Clearance around 30 all the way up to 90 mLs per minute, which is quite high. Whereas we'll see with the newer ones, they're more lipophilic. And therefore they've got an increased half-life, and that explains a lot of their popularity. So, these drugs inhibit protein synthesis like everything else does in the rest of the handout. Compounds, the tests are not very water soluble. We get salt forms of them, but we do that with most antibiotics. But why are they effective? Well, for one thing, the tests are selective to the bacterial ribosome, which is a little bit different binding properties, but also because the tests are brought into the bacterial cell. They mimic a natural nutrient. Therefore, the bacteria actively pump the TETs inside. As a converse, resistance occurs by pumping the TETs out. Obviously, out of the bug. So, but typically these drugs work pretty well. The concentration that's going to be seen in the bug is quite a bit higher than what's seen in the eukaryotic mammalian cell. So that's our selectivity. Different ribosomes, different concentrations. And when we look at the oral absorption of the TETs, a couple of things here. Don't want to get too much into the chemistry here. Let's focus on the lipophilicity. These two are the newer ones. Doxycycline and minocycline. They're more lipophilic, and because of that, they've got better oral absorption, and they're missing a hydroxyl group. I don't want you to focus on that. I'm just more concerned that you remember that they're more lipophilic. One of the problems we have with the tetracyclines is they're not very water soluble. One of the tetracyclines, of course, is tetracycline. It has a low water solubility. A lot of them do. And when we need these, the hydroxyl and the oxygens, these polar groups, are needed to interact with water. To break into the polar water molecules are all attracted to each other, but you need to break into that matrix of water molecules to be able to have solubility. Well, this M double plus here, that stands for divalent metal cations. Things like calcium, magnesium, aluminum. These compounds with these metal ions, which are common in antacids, they'll actually tie up those polar groups that we need in the tetracycline molecule, and they'll lead to a decrease in bioavailability or a decrease in absorption. So let's say down here, patients try to relieve the gastric irritation by drinking milk or taking antacids. Therefore, yep, it's best to take these without food, without dairy products, just on an empty stomach. You know, sometimes patients will say, well, can I take it with coffee? I say, yeah, if your coffee doesn't have any cream in it. But it's just best to take them on an empty stomach. Otherwise, you know, these antacids will decrease GI absorption. And the drug just goes out in the stool. It's a waste. The patient doesn't get any better. So, looking at the half-life, again, the two bottom ones here are the newer ones. Look at the nice long half-life of doxycycline and minocycline, 20 hours. And therefore, much greater use. These are dosed sometimes just once a day, maybe twice. Whereas tetracycline at the very top there, well, probably a dose at Q6 hours. With these you can dose once daily, or BID. Quite often you can get away with just once daily, so that makes a huge difference. And excretion, instead of in the kidney, some of it goes through the kidney, but some of it goes into the stool, some in the bile, some of it's biotransformed, kind of a hodgepodge of things for, again, doxycycline is the big star here. And I don't want you to memorize these numbers by any means, but they kind of follow in line with what we'd expect. Doxycycline, minocycline, they're more lipophilic, therefore they hate water, therefore they have higher protein binding. Therefore they have less in the urine. You will see more of them going into the bile, because that's how the body's trying to get rid of them. But this last category also makes sense. It's looking at the gradient in the CSF. What's the CSF concentration compared to the plasma concentration? And what we see with doxycycline, I'm going to pick on it again, you get nearly equal concentrations, 50% to 100%. 50 to 100% of plasma concentrations. So again, it underscores this lipophilicity of these drugs. It also lets us know we're going to have really good tissue penetration with these. They're going to have a large volume of distribution. They'll spread out everywhere. Because of that, they have good efficacy against a lot of bugs. So, let's see, toxicity. Of the older tests, I've got newer tests on the next page, but it's very, very common. There's some mild nephrotoxicity, GI irritation, things that I would pick on the exam, you guys. Points number 4 and 5. Points number 4 and 5. A pregnant woman shouldn't be given tests. Mother's liver is burdened, and particularly when we start talking about doxycycline, but the test can cause some liver trouble. But probably more importantly, the fetus teeth and bones contain divalent cations, which can chelate these drugs. Remember, there's this calcium phosphate crystal in bone that will attract the tetracycline. And that'll inhibit fetal bone formation. In addition, just in a pediatric situation, the teeth will turn a permanent gray when they get exposure to sunlight. So we don't use these in children, really, I say under 12, but really even under 14. You want those teeth to be well formed. And this relates a little bit to this next problem. The tests are unstable compounds, which get broken down upon exposure to sunlight, causing a phototoxicity. Doxycycline will cause a blistering sunburn. You just can't go out in the sun with it. Even here in Indiana, in the wintertime, talking with the veterans at the VA, I'll warn them of this, and they'll say, well, wintertime here. I go, yeah, but are you going to Florida? 20 to 30 minutes out in the sun, particularly in the summer, can absolutely scorch you, depending on how strong the sun is on a given day. So you really have to watch out for it. Just cover up. As I said, the newer tests are about the same as the older tests, the doxycycline and cycline. Maybe there's less renal damage, but nothing that I would really pick on there. I'm mostly interested in the sunburn, and you're not giving these drugs to a woman who's pregnant. So the indications for these drugs are kind of all over the place. And I say for TET use, but you know what? Let's just say for doxycycline use. What are the indications for doxycycline use? Some urinary tract infections. Yeah. Suppressive therapy and chronic pulmonary infections. This is more for like somebody with COPD. The pulmonologist will say just once a month, use it for 5 days or 10 days. I'll just say treat for the first week each month would be real typical. But they're not really thinking they're going to clear everything up, but just to suppress it and keep it down. Chlamydia, these drugs are drugs of choice. They're also going to get mycoplasma pneumoniae. It doesn't have a cell wall, but we don't care about cell wall. This is protein synthesis inhibition. So I look at those two, and the fact that plus we get Haemophilus influenza, plus strep pneumoniae, well, we start to see it, those are bugs that are very commonly causing pneumonias. So we can use these to treat respiratory infections. Rickettsia, they're drug of choice. Tell you, yeah, brucellosis, tularemia, cholera. Yes, could they be used as a backup to penicillins? They could. It's just not done very often. 6 through 9 there. for your information only. The idea of using, somebody's allergic to penicillin and you're treating syphilis, quite often we'll admit them to a hospital and do a desensitization protocol where we deplete all the mast cells by slowly giving the penicillin rather than trying to give something else. But Lyme disease, these are the drug of choice again. The Borrelia burgdorferi that cause that. The H. pylori that causes the GI ulcers. That can be part of a drug combo. But I actually don't see it used for that a whole lot. So, look, even 11, I'm going to say your information only. You can remember doxycycline is a drug of choice for Lyme disease, rickettsia. It's good for respiratory infections, whether it's suppressive or somebody's got an active infection, and it gets some urinary tract infections. Those urinary tract infections are probably going to be better treated with one of the other tetracyclines that goes out in the urine. We've got so many other drugs for urinary tract infections. So respiratory infections, rickettsia, Lyme disease are the big uses of these drugs. Tetracycline is a new one. I mean, it's new as in the last 5 years. Structure very similar to tetracyclines when we look at those 4 rings. Its action is very similar to tetracyclines, but slightly different. Structure gives it better gram-negative coverage. So it gets gram-positive, but it'll get more of the gram-negative infections. So I'm seeing some use of it yet, still, but it's timing. We'll see what happens. Okay, chloramphenicol. Not used in the U.S. So you might say, why do we have it in the notes here? And that's actually that's certainly a good question, and I've got a partial answer to it. First of all, what did chloramphenicol do? It's a protein synthesis inhibitor. In a lot of ways, it's similar to the tetracyclines. You can have some resistance. I wouldn't worry about any of that. Or its toxic reactions. You might think bone marrow suppression is one that I really care about. I don't. Gray baby syndrome develops if the drug is used in neonates or in pregnant women. The neonate can't metabolize the drug. And they'll develop an accumulation of it, and they'll get a paralysis, a cyanosis, and it can be quite awful. So we don't use it there. But this is really the big reason we don't use it. So I would say know those 2 side effects. Aplastic anemia. And point A there is bone marrow suppression, but that's during therapy. It's dose related, and if you start getting some suppression, you just quit the drug. It's not that big a deal. But weeks or months after therapy, and it's totally unpredictable, it's idiosyncratic, and therefore it's not used in the U.S. However, it is used across the world. It's a good drug, 1 in 30,000. For those of you that have gone on some of these mission trips, worry about 1 in 30,000 people getting an aplastic anemia from a drug when you've got a dirt cheap drug that works well. That's not a reason not to use it. So it certainly has worldwide use. And that's why you might see it on your boards. But if you guys can keep in mind, it's a protein synthesis inhibitor. You don't want to use it in babies, pregnant women, because of this gray baby syndrome. And there's this strange, unpredictable aplastic anemia. You're doing great. Okay. Let's see, the macrolides. Erythromycin certainly is old. Azithromycin, clarithromycin, I don't want to say they're new, but they're certainly, again, they're newer. And you look at the structure there, it's unlike anything else we've seen to this point. It's certainly not a beta-lactam, it's not an aminoglycoside. It's its own little beast, but certainly it's not going to be sensitive to a lactamase. So this group, they're effective against gram-positives that get staph and strep. Not susceptible to penicillinases, therefore Staph aureus is vulnerable. Let's see, azithromycin and clarithromycin have some use in treating this Mycobacterium avium, which is a related to tuberculosis. I'll mention it next week when we cover TB. Now, people have fallen in love with azithromycin and clarithromycin. Two big advantages of these drugs. One is they're easier to dose. I don't want you to remember this dosing, you guys, but look at this. The erythromycin was 4 times a day for 7 to 10 days. Well, clarithromycin is twice a day. That makes a huge difference. But azithromycin, it's given in different ways, but one of the most common ways it's given is 2 tabs on day 1, then 1 every day for 4 days. That is really remarkably easy. So the dosing schedule has held a lot, but they've also got fewer GI effects, which I'll talk about down below. Let's see, erythromycin gets Legionella, and that's worth knowing. You want to know that. It works better than the other macrolides for that. But then we look and we say, all right, we get mycoplasma, chlamydia in one big dose. That's with azithromycin, but we're not going to focus. Yeah. Haemophilus influenza, plus we get strep pneumoniae, plus we get Staph aureus. You start looking at that and you're going, wow, that's a lot of respiratory bugs. So when we talk about azithromycin and clarithromycin, a lot of respiratory infections. That's actually coverage that's very, very similar, not exact, but very similar to what doxycycline showed. Doxycycline didn't get the chlamydia. Excuse me, it was a drug of choice for chlamydia. What is the difference here then? Really, that's really close. Perhaps the Staph aureus might have some trouble with the doxycycline, but those two profiles of what they get are very, very similar. They penetrate well. A couple of notes here on erythromycin. Degraded in the acid environment of the stomach, so what? The drug can be it can be coated. That's not so important. Actually, I don't care about those 2 points. What I really care about is this one. Adverse reactions. There are receptors for erythromycin on smooth muscle cells that, when stimulated, increase GI contractions. Therefore, this is used by GI MDs for people with diabetes that don't have good motility anymore. I'll just say to stimulate motility. If you're using erythromycin, it plays around with a lot of the people, 50 families. Azithromycin, clarithromycin, not so bad, but erythromycin causes a lot of trouble. So I should have included down here, we certainly get resistance to these drugs, and the main mode of resistance occurs, which is common for protein synthesis inhibition. It occurs by changing the binding sites. On the 50S ribosome. They're good drugs, but we certainly get some resistance to them. Okay, clindamycin. When you guys think of clindamycin, I want you to think of getting anaerobes, because that's really what it's used for. Yes, it's a protein synthesis inhibitor. I don't want to skip over all this, but all this stuff is protein synthesis inhibitor. It even works on the same side as some of the macrolides. Yeah, sure. Is that what you're thinking, Davika? Resistance occurs by changing binding site on the so, yeah. But I can stick in there macrolide. Resistance occurs by changing the binding site on the 50S ribosome. Clindamycin is very similar to the macrolides. It even overlaps binding site with erythromycin. I say erythromycin resistant, but I could just say macrolide resistant. Bacteria that are resistant to macrolides are often going to be resistant to clindamycin. And the spectrum here, I don't care so much about the spectrum. It gets gram-positives, okay, staph and strep. But this is really, it's all about anaerobic bacteria. So if you're using clindamycin, it's usually to get an anaerobe. And it'll work on most anaerobes. It is not effective against Clostridium difficile. So, as a matter of fact, it's probably about one of the worst drugs for causing an overgrowth of Clostridium difficile. So, but it'll also get Bacteroides fragilis. You'll see a lot of it used in a hospital setting, and it's also given orally. Dentists like it. You get a lot of anaerobic infections in your gums. So, this drug is especially good at causing the overgrowth of the Clostridium diarrhea, Clostridium difficile, and the horrible pseudomembranous colitis. Again, I think I've mentioned this before, but loperamide, which is an antidiarrheal, you don't want to use that when somebody's having this diarrhea. And the problem here, again, this colitis, it'll show up weeks or months after therapy. And sometimes if it's 2 months later, it's kind of hard to tie in. Patients will certainly have a hard time tying that in, but if you're not doing a good history saying, have you taken any oral antibiotics in the last year? But quite often, patients aren't going to pull that together, and they'll start taking the loperamide, which slows down the gut, which just allows that toxin to sit in there longer and longer. So, vancomycin can eradicate the Clostridium, I should say, or metronidazole. We haven't talked about metronidazole yet. The problem with metronidazole is I'm seeing a lot of resistance to it. But I know on the boards they still ask that a lot. Use metronidazole or Vanc, so you kind of got to know both. So, let's see, I noticed at the bottom there, I just went by this, ampicillin is also an important cause of Clostridium overgrowth. That's when it's given orally. You're much better off to use amoxicillin orally. It was the oral ampicillin, and it gets a lot better absorption, so you'll avoid some of this problem. Better GI absorption. And you get it out of the gut and cause less trouble there. Okay, Mupiricin, topical. Unrelated to anything else we've talked about, I do have used topically in here. You could use it for the treatment of skin infections like impetigo, which is caused by staph. Even when it's penicillinase producing, even when it's MRSA. It can be used for strep, but it's really this is giving it a lot of use. People that are going in for surgery, for a knee surgery, they'll actually culture the nasal cavity and see if there is any MRSA there. If there is, they'll use this with the swab up there to eradicate it, to prevent joint infection. It's very easy to touch your finger to your nose and then touch it to the incision, and that might be how it gets spread. There may be some other ways. But this gets used for treating nasal colonization. It also gets treated for nasty diaper rashes that can be causing some impetigo. So staph, strep is what I'd keep in mind. MRSA, of course, is a staph infection. So what does it do? I've got a lot written here. I kind of wonder if we can simplify this. Let's just keep in mind, it reversibly binds to a bacterial transfer RNA synthetase. And with that, we'll get a depletion of a particular transfer RNA and inhibition of protein synthesis. Actually, if you guys want to just remember it's protein synthesis, it's inhibited, I think that's fine. But a useful compound. Okay, drugs that we use for VRE, vancomycin-resistant enterococcus, and I could say, vancomycin-resistant Staph aureus, because it looks like VRE through a plasmid transferred this resistance to the staph. So staph went from good old staph to penicillinase producing staph to MRSA and finally to this Versa. So with this VRE, keep in mind the D-alanine was converted to D-alanine D-lactate. And that lactate will prevent vancomycin binding. I touched on this in the first antibiotic handout. I'll send you back to that if it's not for me. I mentioned this. This is what strains of enterococcus that are resistant to vanc have done. So, some big guns that we've got. Linazolid. Strange looking structure there compared to anything else we've seen. But again, binds the 50S ribosome, prevents the formation of a functional complex. Like most protein synthesis inhibitors, it's static. Against staph and strep, it actually is against staph and enterococci. It actually has some stronger activity against strep. When would you use this drug? Well, certainly vancomycin-resistant enterococcus, frequently with an aminoglycoside. You could use it as an alternative to vancomycin for MRSA, for somebody who can't tolerate the vanc. So, two pretty important uses, VRE and MRSA. Yeah. It can be given orally, it can be given IV, but a tablet of it is $45, and you dose it twice a day. That's probably a little bit higher than that. Now you're looking at least $100 a day. For 10 days, you're looking at $1,000 for an over-the-counter antibiotic. It could be IV or oral. It can be IV or oral. So I see a lot in the hospital setting, but you could have somebody treated on an outpatient basis, but just be careful when you use it. That cost is prohibitive. And of course, they know they can charge that and get away with it. If you can be treated as an outpatient, you're going to save a lot of money despite the cost of this. It does have this peculiar property that we don't see very often. It inhibits MAO, monoamine oxidase. So you got to watch out for tyramine and the sympathomimetics. Some bone marrow depression also occurs, but a really useful drug. We're trying not to use it too often, but it's so popular because when somebody has the VRE, this is one of the first drugs they jump to. Quinupristin, dalfopristin, it's just not being used much. I don't really have anything to add to what's written there. I'm just going to say it's your information only. It's not on your drug list. I'm just not seeing it used enough to warrant discussion of it. The daptomycin, though, when I see someone with VRE, they're either getting dapto or they're getting the linazolid. And the dapto is a wild-looking structure. Look at this thing. A cyclic lipopeptide. And this is a new class. It's in its own class all by itself. It works against a lot of gram-positive organisms. It perhaps works better than a lot of the other drugs we've talked about, vanc or linazolid. But currently, we're using this drug for VRE and MRSA infections. So the indications are pretty much what linazolid was, VRE, MRSA. And then there's this crazy mechanism. Daptomycin is distinct from any other antibiotic. It binds to the membrane. So this is a protein synthesis inhibitor handout. But I believe I said, go way to where we started last week. I hopefully said this. Yes. Yeah. All drugs in this handout inhibit protein synthesis except daptomycin, the very last one. And I have to put the daptomycin in here because we're talking about the drugs for VRE, and that's what it's used for. But this drug binds to bacterial membranes and causes a rapid depolarization, which leads to cell death. Protein synthesis is inhibited, so it seems to open up pores into the membrane. So, very peculiar mechanism of action. Well, now handout 33 here. Need to talk about sulfonamides. They're old, but they're still very, very useful, particularly when they're combined with trimethoprim. But folic acid is this vitamin, 3 parts of it, glutamic acid, have a pteridine ring. If you remember back to the methotrexate cancer lectures, we discussed the structure there. Methotrexate was just an analog of folic acid. But humans can take in folate in the diet, and from that will produce the tetrahydrofolate. And that, of course, goes for 1 carbon transfers. Bacteria can't take in that folate. They have to produce it from precursors, and then they form the tetrahydrofolate. I forgot that I had this typed in here. But the tetrahydrofolate is an important cofactor for various 1 carbon transfers, used in amino acids, purines, and pyrimidines. So, bacteria have to produce the dihydrofolic acid. We used to call it dihydrofolic acid synthetase, that would convert the PABA to the dihydrofolate. That's sort of an old name. This is the newer name. The dihydroopteroate synthetase. And why they made that change, I'm not sure. But anyhow, that produces the dihydrofolate, and the dihydrofolate then gets further reduced by the dihydrofolic acid reductase to the tetrahydrofolate. Let's see, this first enzyme is inhibited by the sulfonamides. The bacteria DHFR, what I like to call this, is inhibited by trimethoprim. And a little hard to read my writing there. TRIMETHO. Trying to avoid this pharmacist revenge syndrome I sometimes get into. The ways that we see resistance is sometimes the bacteria increase the amount of PABA, and this is a competitive inhibition. Like the first synthetase enzyme there. So we can see resistance, 1, by increasing the PABA concentration. Bacteria just keep making more PABA, the paraminobenzoic acid. Or we can actually have a change in the enzymes. The enzymes will change their sensitivity. They won't bind the drug as avidly. So there's been some sort of a change probably in their primary amino acid sequence to allow for that. But these are old drugs put together frequently. The sulfonamides with the trimethoprim, you might think, oh, come on, something that old can't be useful, but they are. We do get a nice selectivity. So initially here I start talking about just the sulfonamides all by themselves, and I rarely see that anymore. But looking at sulfoxazole and sulfamethoxazole, and sulfamethoxazole is the one that's on your drug list, inhibits the, I've still got DHF, I've still got the wrong enzyme listed here. It's a dihydroopteroate. But with that, bacteria become starved for amino acids, purines, and pyrimidines. They can't do those 1 carbon transfers that are needed. And growth ceases, death occurs. Uses of these drugs, we have to keep high concentration. Sometimes that's a little bit hard. If you use a sulfonamide all by itself, it's not going to work. But these drugs are eliminated by the kidneys. so concentrated in the urine. So urinary tract infections are for primary indications for, I would say, solo sulfonamide therapy. But why would you go solo? If you have the trimethoprim on, you'll do better. Let's see, resistance. I mentioned this on the previous page, but there is an additional. There's the increase of PABA, but there's also salvage of amino acids, purines, and peroxidines from the environment. So, particularly in an area where there's a lot of tissue destruction, you get a lot of tissue breakdown. The bacteria start just using what's there rather than worrying about having to make amino acids and nucleic acids. So, if you're talking about treatment of an abscess, the bacteria, these drugs will not work well. And as far as toxicity, skin rashes, probably the most common drug to cause a skin rash is the sulfonamide, at least in my experience. Just taking allergies over the last 20 years from patients. As soon as they say they have a skin allergy to a medicine, I can just about bet they're going to say it was the sulfonamide. Just very, very common. Additionally, these drugs will displace bilirubin in neonates, and so you cannot use it in a neonate or a pregnant woman in her last trimester. So, for the last trimester, either you don't know when the woman's going to hatch the child. So, okay, looking at trimethoprim. And again, which is almost always combined with the sulfamethoxazole, we get this competitive inhibition of the DHFR. And you might say, well, both man and bug here have the DHFR, but it's a different enzyme. So when we look at the trimethoprim concentration required for 50% inhibition, the bacteria, the E. coli, the staph, the proteus, it's a fairly low concentration, but in the mammals, it's a different enzyme. And it has far less sensitivity. And therefore, we do have selectivity. It may sound like it's the same enzyme, but we're going to get the selectivity that we need there. So, as I mentioned, these two drugs are almost always put together. There's some rare instances where I've seen trimethoprim alone, but it's, let's see, synergy of action between these two drugs is why we put them together. And we look at this table here. Staph and strep, of course, are gram-positive. The Haemophilus and Shigella are gram-negative. And what we see are the minimum inhibitory concentrations, alone or in a mixture. And each of these cases, we do way better with the mixture. So, very good synergy. Therefore, why use one of them alone? Somebody might have an allergy to trimethoprim. There could be something like that. I'm just going to say, I just don't see them used apart anymore. 15 years ago, I did for some eye infections, but I'm not seeing that anymore. So, what do these drugs get used for? Urinary tract infections, upper respiratory infections. They're still very good for it. They're going to get staph. They're going to get strep. They're going to get Haemophilus influenza. That's a lot of your respiratory pathogens. They also get the pneumocystis jirovecchia pneumonia, which we used to call pneumocystis carinii. Seen in AIDS. So occasionally, quite effective. This is just much different. I would not test you guys on that, but it's high dose. When you're going after that protozoa, it's a much different dose. But toxicities are mostly due to the sulfa. Again, it's the skin rashes and the kernicterus and the bilirubin displacement. So what we found is we need a ratio of sulfamethoxazole to try nothing better than 20 to 1. And a combination of 400 to 80 will give us that ratio in vivo. So half-lives of the drugs are approximately equal, so neither accumulates. But usually, just kind of a side note here, we use the DS, which equals the double strength. Your information only here. It's the 800/160. Most commonly these days, that's what you're going to see. But we don't worry about doses in this course, so I'm not. That's why it's your information only. But a lot of these drugs, many of you have used in probably the past 5, well, less than that, probably in the last 2 or 3 years, and just to kind of help clarify that. But again, to get that 20 to 1 ratio, we have to get these doses of 400 to 80. That ratio of 400 to 80. I'm going to say it this way: 400 to 80 oral will lead to the 20 to 1 ratio in the plasma. Okay, good place to take a break. I'll catch you guys back in a few minutes. a note before I pick this back up again, you guys, to remind you that this is some of the more tedious material of the course for me. For me to teach, it's never the part I look forward to. But I can tell you, being in the clinic, it's some of the most useful information that you're going to get in the course. So a lot of this detailed stuff, I can seem overwhelming. You'll use it. You really will. There's nothing that I can think of that I was constantly trying to recall from class lectures while I'm in the clinic. A doctor would ask a question. This is the material I'm always pulling back. And it's neat because you actually cure somebody versus treating their diabetes, their hypertension, their heart failure. So, but it is kind of a bit of a parade of different drugs for different bugs. I understand that, but hang with it. Okay, the quinolones. Nalidixic acid, I can call old. Ciprofloxacin, levofloxacin, moxifloxacin, new. These drugs inhibit bacterial topoisomerase, which is responsible for resolving superhelical twist in DNA when it's being copied. You start to pull away those two DNA strands and you create a lot of torsion in front of the loop there, so you've got to resolve that so you can copy the DNA. Well, before I look at this, I just want to jump down. These are great drugs. Let's look at why. Nalidixic acid's old one's used for urinary tract infections, but Cipro, Levo, and Moxie, broad spectrums, they have that fluoride atom in their structure. But what makes them really great is I've got down there, they're oral antibiotics for gram-negative infections. Even Pseudomonas is sometimes sensitive. So UTIs, respiratory infections, we'll talk about that more on the next page, but this was the first group of drugs we really had where we could say, wow, we can get a nasty gram-negative infection treated outside of the hospital without having to worry about nosocomial infection. So these drugs have been incredibly important for the last 20 years. Let's see, a note on topoisomerases, as if everything else wasn't confusing enough. This diagram looks at topoisomerase 2. We've seen something very similar with the cancer lectures, but I just want to mention bacteria. They have two types. Type 2 topoisomerase. And this will help keep things clear. One, they have DNA gyrase. Gyrase. And quite often people just talk about the DNA gyrase as if it was a different kind of a topoisomerase. It's a subset of type 2 topoisomerases. And as we'll see in the diagram below, if you don't remember, type 2 means you cleave both of the DNA strands. So there's the DNA gyrase, and that's used for the supercoiling. Supercoiling regulation. But there's also topoisomerase 4. And sometimes this was the topoisomerase that's more effective. It depends on the strain of bacteria. But this particular topoisomerase will resolve what's called catenanes, C-A-T-E-N-A-N-E-S. And I'll come back to what those are. But if you remember discussion, let's see, anthracyclines, on the atopa side, back with the cancer lectures. A segment of DNA comes in. We're not going to worry about whether it's the G segment or the T segment. I don't care about that. But a segment comes in. A second segment comes in. We've got a first segment, the second segment. It comes in and associates get strand cleavage. So we'll get cleaving of the first strand. And when did you get passage and then resealing? So assuming both of those occur, the DNA gets passed through and we've got a change in the coiling. Well, so as I've typed in there, result of each cycle is a change in the coiling of DNA, or when two separate circular DNA molecules are involved to resolve these catenanes. In other words, you copied your DNA, but you've got two intersecting pieces of DNA. They're going to have to be separated before cell division, and with the topoisomerase, those can get separated. So it could be, if you inhibit these catenanes, that's another way of inhibiting cell growth. Additionally, at therapeutic concentrations, quinolones also promote topoisomerase subunit dissociation. So you wind up with these double breaks. You get the breaks, but you don't get any resealing. So it's all about playing with the bacterial DNA. Unfortunately, we do see some resistance. And resistance that we're seeing is sometimes the topoisomerase changes its sensitivity to the drug. And it's just not inhibited anymore. And sometimes the drug is pumped out. Pumped out of the cell. So, that's the bad news, is we are seeing some resistance. But indications. When Cipro was the first one that came out in the 90s, everybody thought this was the greatest antibiotic since penicillin, and they were using it for respiratory bugs like a staph or a strep pneumoniae. It doesn't work for gram positives. It just works for gram negatives. It undergoes a lot of renal excretion, so it's great for UTIs. Excreted by the kidney, therefore UTIs. And it's one of the very best drugs for treating UTIs. Levofloxacin, it picks up some of these gram positives. These are added. So we start looking at staph and strep, Haemophilus influenza. We start thinking respiratory infections. And then with moxifloxacin, we pick up the anaerobes. So we get gram negative, gram positive. We pick up some anaerobes. Quite often, if you've got a mixed infection, like a diabetic foot infection, with a diabetic foot infection, you've got to cover anaerobes, but you also want to get the staph, the strep, and the gram negatives. So, interesting drugs, very heavily used. Problems with joints. Young animals seem to be prone to degeneration of cartilage in the joints. They knew this right off the bat before the drug was marketed. They also knew how great these drugs were. I don't say that very clearly. The young animals were prone to degeneration. Nobody wants to find out if this is true in humans. Therefore, no pediatric use. It'd have to be an absolute must drug where you're saving the child's life to use one of these because they will have problems with their joints. Because even adult patients are suffering tears in Achilles tendon while taking the fluoroquinolones. It's been kind of crazy. And my small church of 200 people, I've seen 2 or 3 people, parishioners, that I walked up to and I said, "So, Kate, you've been on an antibiotic?" And they look at me really strange and they go, "How do you know?" I go, "You're walking like your Achilles tendon hurts." And they laugh and they go, "Yeah, it's on this levofloxa." I'm like, "Yeah." So supposedly the rate is like 1 in 5,000. I'm surprised how frequently I've seen it personally. I know you shouldn't go with anecdotal evidence in medicine, but it's kind of alarming. It's like, maybe this is happening more often than we're realizing. But still, you avoid a hospital stay. There's so many problems with the hospital stay besides expense. So, additionally, much like the tetracyclines, absorption from the GI is inhibited by divalent metal cations. But, I just tell patients, take on an empty stomach. And I'm not going to write it down, but the levofloxacin is given just once a day. The ciprofloxacin is just twice a day. These are extremely easy drugs to dose. Let's see, nitrofurantoin. I don't know how I got but 4 in there. Get rid of this. Broad spectrum, excellent. They got excellent oral absorption. And they concentrate in the urine. Nitrofurantoin does. It's used to treat UTIs. I'll just mention its mechanism of action mirrors metronidazole down below. It's reduced by bacteria, and that reduced form will bind to DNA, and that'll lead to cell death. So, strictly for UTIs, that's it. Somebody's on nitrofurantoin, it's to treat a UTI. And it might seem a little tedious, but believe me, I've sat. One of my daughters had a lot of trouble with UTIs when she was young, and I can remember sitting with a pediatrician, and we were both puzzling, going over what antibiotic do we use. We tried this one, we tried this one, we tried this one. And nitrofurantoin came up, and we used it and it worked. But it's really nice to have a selection of 4 or 5 different drugs you can go through. Okay, metronidazole, reduced in anaerobic environments. Therefore, use on anaerobes. So it needs to be reduced. And nitrofurantoin doesn't have to be on an anaerobe, but the metronidazole does. And a couple of ways that metronidazole can be reduced. It's a prodrug, and its reduced form is active. And sometimes it gets reduced by nitroreductase and NADPH. Other times, there's this enzyme, pyruvate ferrodoxin oxidoreductase, PFOR, that's reducing pyruvate to acetyl-CoA, or oxidizing pyruvate to acetyl-CoA, so it reduces the ferrodoxin. And with that, we get this reduced ferrodoxin that can then be used to activate the metronidazole. This active form, the reduced metronidazole, formation of cytotoxic intermediates that cause DNA, protein, and membrane damage. So, bind DNA. It's one of the prominent things it does. It leads to cell death. So, when do we use metronidazole? Used in serious anaerobic infections, something like beef rage. Would be very similar to clindamycin. Those are two of the biggest anaerobic antibiotics: clindamycin, metronidazole. Oral use can be for Clostridium difficile that's causing the diarrhea. It can also be used for vaginitis caused by the trichomonas or the Gardnerella, which are protozoa. Not too many side effects. But if you remember disulfiram, I'll see the ethanol handout. Disulfiram inhibited the second step of alcohol metabolism. So you get the alcohol acted upon by alcohol dehydrogenase to form the acetaldehyde. The acetaldehyde is toxic. You need that to be metabolized very quickly to the acetate and water. Well, in some patients, not everybody, there's a disulfiram-like reaction when taken with ethanol. And disulfiram, as I see the ethanol handout, this drug, disulfiram, inhibited the second step in alcohol metabolism. You get the buildup of the acetaldehyde. Well, somebody that is on metronidazole, they'll take ethanol, and it'll lead to lots of nausea and vomiting. You guys will find your kids don't listen to you. Familiarity, it's like, my son was on metronidazole, and he calls me up after about 7 days. He goes, "Dad, I'm sick as a dog." I go, "So did you have a beer?" He goes, "I forgot." It's like, "I bet you won't forget again." He goes, and all he had was a couple beers. And you don't know who's going to, it's very common, not everybody's going to have it, but it's common enough we have to warn everybody, don't drink when you're taking metronidazole. Therefore, no drinking. And quite often those labels that the pharmacy puts on the prescription vial, quite often when it's with metronidazole, there's something on there. One of the stickers will say, one always says finish the antibiotics, but the other will say do not take alcohol. Okay, this looks like something nasty to memorize, and actually you guys already know it. But you can break these antibiotics into four main groups. Those that are cidal, even on resting organisms. Those that are cidal on proliferating organisms. Let's look at this first two. Group 1, cidal on even a resting microorganism, is the aminoglycosides. See, gentamicin, tobramycin, amikacin. So they're bactericidal even on a resting organism. Whereas the beta-lactams need the growth to be occurring. So the penicillins, the cephalosporins, bacitracin, bank, these are cell wall inhibitors. And everything else after aminoglycosides and cell wall inhibitors is bacteriostatic, and these are mainly bacteriostatic. It does say in high concentration also cidal, but we really don't think about that. But these are your protein synthesis inhibitors: chloramphenicol, tetracyclines, clindamycin. And then the last category is exclusively static. These are drugs I just never see. The cycloserine, I'm not even sure how to pronounce those last two there. One of the keys, though, to this table, why it's useful is you don't want to combine categories 2 and 3. The bacteriostatic effect of the protein synthesis inhibitors will render the cell wall inhibitors pretty useless, because the cell wall inhibitors need that proliferation. So if you slow down the growth, cell wall inhibitors aren't going to be useful. Okay, broadening of the antimicrobial spectrum, these combinations that we sometimes use. If you're trying to, if you've got a mixed infection, where you've got to eliminate several different things, like an intestinal perforation, a mixed infection, there's a couple of different ways we can go at it these days. You're going to have gram-negs and you're going to have aerobic bacteria. So gentamicin and aminoglycoside will control the aerobic gram-negative, and you can add clindamycin to take care of the anaerobes. Put a fourth category in here. Or you could use imipenem. Imipenem was the carbapenem. It's not a cephalosporin, it's not a penicillin, but it's a carbapenem. But it got gram-positive, got gram-negative, got anaerobes. So you could use imipenem, and it's combined with cilastatin. Cilastatin prevents the metabolism of the imipenem. You could use the imipenem cilastatin alone. Sometimes for endocarditis, when you need really aggressive bactericidal action, a synergism with a penicillin and an aminoglycoside can be used. Certainly for Pseudomonas infections, I've got carbenicillin listed here, but it's really the piperacillin. Piperacillin, tazobactam, that would be used with aminoglycoside. And for a UTI, as I mentioned earlier in this handout, the synergism of sulfamethoxazole and trimethoprim. Quite often, though, we also use these combos to prevent bacterial resistance, and we'll talk about this more next week. But tuberculosis therapy, which is 6 to 12 months, and resistance becomes a big problem with that. And a lot of the pharmacology books mention streptomycin in treating tuberculosis. Being a pharmacist, I always frown on that because I'm like, nobody does that. Streptomycin is an aminoglycoside, therefore no oral use. In 6 to 12 months of injections, nobody does that. But since resistance is likely to develop, we use 2 to 4 drugs. I'll just say it's in the next handout. We'll talk about that a little bit more in depth. Last thing though, as I mentioned, some combos actually fight each other, and a penicillin and a tetracycline, something that's bacteriostatic, won't work well. Okay, you guys sometimes frown at this, and I sometimes get questions like, do I really have to know this, Dr. Z? And it's like, you guys, this is where the rubber meets the road. This is where, if I was rounding with, certainly with an ID doctor, if I was just rounding with an infectious disease doctor, an internal medicine doctor, I'd know this stuff, because they're going to be asking it of you, and it's just too useful. So, looking at urinary tract, and this is commonly used drugs for common infections. But UTIs, you need a drug that undergoes renal excretion. And what are the bugs that normally cause it? E. coli, Proteus, Clab, Pseudomonas, maybe some staph. Notice these first 3. That's Proteus, E. coli, Klebsiella. That could be a first-generation cephalosporin. something like cephalexin. And a first-generation cephalosporin will also get the staph. So, there's some flexibility here in what you use. The cephalosporin first generation is not going to get the Pseudomonas. The trimethoprim sulfamethoxazole will get a lot of these. Look at Cipro, it gets it all. Cipro even gets Pseudomonas in the urine. Obviously though, this is not used in children due to the joint problems. If you've got a really nasty infection in a child, you're probably going to want to use something like ampicillin. And when you think about ampicillin, it gets Proteus E. coli club. It's very similar to what the first generation cephalosporin will get, but ampicillin plus an aminoglycoside. So, years ago, one of my children was on this for a nasty E. coli infection that got up into the kidney. Took about 36 hours, and the fever broke, and a wonderful moment to have your sick child suddenly run across the room and hug you. It's like, whoa, these drugs, they're boring, but they are so freaking good. Let's see, skin infections. Usually strep pyogenes, maybe staph, aureus or staph epidermidis. When I think about skin infections, I think about the first generation cephalosporins. And both of these will get cephalexin, cefazolin, or first generation, and therefore they resist staph lactamase. But so will the nafcillin and the amoxicillin clavulanate. They'll also work there. Let's see, for pressure ulcers or for diabetics, you want to get some really broad coverage here. You want gram-positive, gram-negative, and you also want to catch the anaerobes. So piptazo or imipenem-cilastatin can be used. When you've got anaerobes, that means those cephalosporins can be used. Or at least not the main categories of first, second, third generation. Fifth might get it, but we're just not using that drug yet. What's there? I guess not. Going on to MRSA. If it's nosocomial, Vanc is still the drug of choice. But you could use linezolid or daptomycin. We're trying to save those. We don't want to encourage more resistance. MRSA from the community. Depends on where this was picked up, but if it's MRSA from the community, amazingly, trimethoprim sulfamethoxazole works. So, not if we've got an abscess, because the tissue breakdown will lead to a lot of resistance. But if it's a MRSA infection from the community, you can get away with good old sulfamethoxazole trimethoprim. Okay, bone and joint, like an osteomyelitis, where you look at staph and strep. Nafcillin, cefazolin will certainly work. Again, this is first generation. That could be used if MRSA is suspected. You could also use percillin, tazobactam. If you're just not sure, piptazo is so broad in its coverage, that's kind of where people are going. Strep pneumoniae, Neisseria, That's for the simplest, ceftriaxone. You can use some other things. The Neisseria, you can even use penicillin G, but ceftriaxone generally gets used. Doxycycline gets used for the Lyme disease. Benzathine pen G, this was the suspension with a long duration of action of pen G. So it's a suspension form of pen G, but it's the drug of choice for treating syphilis. For gonorrhea, ceftriaxone is a drug of choice for the Neisseria. But then about half the time you've got coexisting chlamydia, so doxycycline is the drug of choice for chlamydia. There's some that are easier. I mean, doxycycline is twice a day for probably a week, maybe 10 days. But nothing works as well as doxycycline for chlamydia at this point. Pelvic inflammatory disease, bugs that cause it, the chlamydia, the Neisseria, B. frag, E. coli. The doxycycline, again, is the drug of choice for the chlamydia. Cefoxitin, which is a second generation Ceph, is going to get all of these. Generally, we don't think of the Cephs as being good at anaerobes, but this is an exception. It will get anaerobes, which in this case is the B. frag. Okay, looking at good old sinusitis and earaches. Let's see. Causative organisms, the strep pneumoniae, the Haemophilus influenza, the Moraxella catarrhalis. There's different ways we can go with this. The Moraxella catarrhalis, these are both gram-negatives. So we got to get some coverage for positives and negatives. The amoxicillin, all by itself, is probably going to have some trouble against the Haemophilus influenza and against the catarrhalis. You can try it, but amoxicillin clavulanate will work better. Certainly better than amoxicillin alone, but you'll have a lot more diarrhea. If it's a young child with a diaper on, they'll be changing the diaper quite a bit, and adults complain about it too. Trimethoprim, sulfamethoxazole comes up again. Notice lipo. It's one of the very best. Notice again, it's just in adults. I'm going to squeeze azithromycin in here. I don't know why that got left out. But azithromycin is going to get those organisms. So again, there's strains of each of those that may resist the azithromycin or the amoxicillin clavulanate, but it's a pretty good bet. And finally, when we get to pneumonias, a lot of different bugs. The last two are the atypicals. But when we look at clarithromycin or azithromycin, look what they get. The strep, Haemophilus, staph, mycoplasma, chlamydia. I mean, that's doing really well. But they miss something. What they miss is the Klebsiella. And that's a big miss. Doxycycline doesn't do quite as well. It still gets used, as I mentioned, for a lot of like suppressive therapy, but it gets this the strep, Haemophilus, mycoplasma, chlamydia pneumonia. But look at this. Those quinolones get everything but the atypicals. So that's great coverage. So when somebody comes into an ER with pneumonia and they're going to be hospitalized, a couple of different things they do to cover. They'll go with this combo. Ceftriaxone and azithromycin. Ceftriaxone is a third generation, and it's going to get the Klebsiella and other things, but you're doubling up your coverage here. Azithromycin would miss that Klebsiella, so that's, you might just say give the azithromycin by itself, but you won't be getting the Kleb. Or you could give the levofloxacin or the moxifloxacin. And finally, for a strep throat caused by the strep pyogenes, Pen-V, I've got the K on there, and I've kind of left it on there intentionally. Pen-V is the oral Pen-G. Okay, so what's that K? K equals the potassium salt. And I just frequently see that on prescription labels, Pen-VK, and it's like, what's the K? Well, it's the potassium salt of Pen-V. It's just to help the solubility. Okay, I'd like to get into the next handout and get through the fungi. And that'll make next week really easy. So. Perhaps, let's see, the fungi are hard to get through. Yeah. Well, I'll take a break. We got at least 10 minutes here, maybe it's 15 or 20. But we'll go ahead and just finish this up and get through the fungi, and then next week we can look at the antiviral drugs. And we'll also finish with some odds and ends. But when we look at the types of fungi, there's those that are localized to the skin, like the tinea infections. Yeah. Topical treatment usually works to get these dermatophytic fungi. Maybe I'll just mention oral sometimes. But certainly we think of topical treatments. The Candida that causes the mucocutaneous, yeah. Often again with topicals. But you can use oral sometimes, as we'll see. But, and the skin, sometimes the skin kind of persistent and they're a pain to get rid of, and sometimes the mucocutaneous can be a little bit. But the systemic infections, suddenly we're talking about a whole different thing here. Far more difficult, far more dangerous, the Cryptococcus, Blastomycetes, the histoplasma. Now suddenly we're talking usually IV. It's usually in a hospital setting. Maybe in a hospital. Sometimes in a hospital, when the patient starts to do better, they can switch to oral. So, what can we do here? We've got ready access to the first two with topical agents. That works well. But for the systemic infections, we're dealing with something here. Fungi are eukaryotic. And therefore, selective toxicity is going to be more difficult. These drugs are generally more toxic. We've done better. We've made some big improvements recently, but it's been difficult. So what can we exploit? Well, the fungal cells are larger, the bacteria so. Cell walls are made of some different constituents, chitin, cellulose, beta-glucans. Sometimes we have some drug that works there. possible treatment there. Say fungal ribosomes or ADS, which is more like the humans or eukaryotes. The big thing that we use, though, is that the fungal cell membranes do not have cholesterol, they've got ergosterol. And that's, as I say here, commonly exploited in drug therapy. When we have to go IV, this is really usually where we're going after. So what are these antifungal agents? First group that I've got listed here, the polyenes, they bind ergosterol irreversibly. They disrupt the membrane. Basically, I say they disrupt it. They put holes in the membrane. Make it somewhat porous. They're highly toxic drugs, though. Amphotericin B has the nickname amphoterrible. You'll see why as we talk about it more on the next page. It's the best drug of the polyenes. It is the best systemic drug available. But I'll just say it's very toxic. Nystatin is so toxic, you can't use it systemically. This surprised me when I first became a pharmacist, because there I was watching the owner of the pharmacy dispense some nystatin for oral use for a patient. I was like, what? What is going on here? It is used topically, but it can be used in oral use. It's a suspension, so it's a liquid. You can have oral use to treat oral candidiasis. The bioavailability is essentially zero. So it just stays in the gut. So it can be used orally, and you would never give it parenterally, though. Way too toxic. Unfortunately, what we found is some resistant strains have lower ergosterol, which I guess isn't surprising, but disappointing at least. All right, so if you're getting a 1-hour infusion of amphotericin, yeah, I'm not clear about that. Amphotericin B, because we're not talking about a 1-hour infusion of the nystatin. By the way, nystatin, cilastatin, they're not for cholesterol, you guys. During a 1-hour, cilastatin is what goes with the imipenem. But during a 1-hour infusion, the patient will have a fever, they'll have chills, they'll be shaking, there'll be a lot of muscle rigor, blood pressure can drop due to the histamine release. We can pre-treat the person with nonsteroidals, antihistamines. Meperidine seems to help. Meperidine is a narcotic. It seems to decrease the shakes. We can also give adrenal steroids, prednisone is what I'm thinking of there. So you can try these pre-treatments. They do help, but this is still miserable. So it's a difficult treatment. Fortunately, it's only once a day, but still, it's a bloody hour each day, and it's not going to be pleasant. Well, the list of any drug for side effects is pretty long, but a really difficult side effects with amphotericin B is still very long. Nephrotoxicity is the big one. It's the major adverse ADR. Major adverse drug reaction. That's what we worry about the most. The GFR goes down. There can be some tubular acidosis, decreased potassium and magnesium, some anemia because the kidneys can't make the erythropoietin. Quite often there's an azotemia, 80% of patients. So people get through it, but they never want to go back to it again. I don't blame them. But that's led to the advancement of some other compounds that are much less toxic. Two other groups of antifungals are the imidazoles and the triazoles. And we put them together because they do the same thing, they're just different chemically. And there's been an explosion in this area. Clotrimazole, miconazole, fluconazole, ketoconazole, all the way down there through voriconazole. So drugs that I picked on that I would put on the drug list, fluconazole is an important one for systemic use. Voriconazole, itraconazole, these systemic use ones, because those are the really nasty infections. So what is it these compounds do? Well, it's on the left here. This is the pathway to ergosterol synthesis. And it looks, of course, a lot like cholesterol synthesis. But what we see is these compounds, the imidazoles and the triazoles, they inhibit this 14-alpha-sterol demethylase. And it's over here. So we don't get the synthesis of ergosterol. So fluconazole, voriconazole are two representative triazoles, great drugs. So much better to go to than amphotericin B. The alkylamines and benzylamines, really the one that we'll talk about on the next page is terbinafine. Terbinafine. Terbinafine just inhibits this squalene epoxidase. It's a little bit earlier. Mentioned over here in the caption. Let's see. I noted about the voriconazole and the fluconazole. These are the two most useful systemic agents. Let's see, administration, as I said above, can be systemic, topical, there's vaginal suppositories. There's also this thing called oral troche, that's how that is pronounced. It's just a lozenge that slowly dissolves in the mouth. And the point is, you don't bite down on it. You just stick it between your cheek and gum and let it slowly dissolve there to slowly release the clotrimazole. And it works great for oropharyngeal candidiasis. Unfortunately, we do see some resistance, and at this point, the major form of resistance occurs by decreasing the intracellular azole concentration. So these fungi, where the polyenes, they bind to ergosterol, so the fungus just made less ergosterol. That's not going to work here because these drugs inhibit the formation of the ergosterol, whatever else might replace it, but the bugs just decrease the picking up of these great antifungal drugs. Okay, and notes on kinetics of these drugs. They can be oral or IV. Fluconazole is the one that gets into the CNF, and CSF, cerebrospinal fluid, can be used for a meningeal infection. The voriconazole will cause variation in the P450s, is how I think of it. It can really mess up warfarin, simvastatin, lovastatin, atorvastatin. Those are your cholesterol drugs that went through the P450 system. Pravastatin and rosuvastatin, no P450 interaction with those. These drugs also decrease the synthesis of adrenal steroids. So, therefore, you can get decreased libido. So maybe some gynecomastia. If you remember back with endocrine, I mentioned that ketoconazole in high dose gets used to inhibit some of the adrenal steroids. So it's not too surprising ketoconazole is used by the endo MDs. I'll just send you back to that handout. See what we talked about there. So those are your great antifungals. Flucytosine, I don't think I included it on the drug list. Maybe I should have, but golly. I know if you called up most hospital pharmacies and said you need this, you'd be on quite a hunt to find it. Just aren't many places. We still use it much anymore, but it's converted in fungi to 5-fluorouracil, which is the anti-cancer drug. So essentially, the fungi are activating a chemo agent. Lots of resistance forms. Griseofulvin, this is an example of an oral administration for treating a topical infection. And it's because this drug will concentrate in the skin. And as the skin is sloughed off, the fungi keep trying to dive deeper into the skin, and this compound will concentrate in the new layers of the skin, prevent mitosis in the fungi. So fungi go down, they go right into this griseofulvin. Eventually this fungus is sloughed off. So let's see. Other agents that I don't care about so much, not that I know of. The great drug for onychomycosis is what we're getting to, is terbinafine. Lamisil is the trade name. Onychomycosis, of course, is these nasty nail infections. We can get it in our fingers, but it's even worse in our feet because with our shoes, that humidity in there, it's really harder to treat. But as I said on the previous page, it inhibits the griseofulvin would be for tinea infections. Tinea capitis quite often is what it could be used for. But the terbinafine, it's kind of it's in a class by itself for treating nail infections. It can be topical, but the great thing is systemic absorption shows accumulation of fat, skin, and nails in the nail bed. You can still find it in the blood 4 weeks after prolonged therapy, so it's still sitting in those nail beds. So sometimes it's a 3-month therapy to treat a nail infection. So, and I do have that in here. But it will last in the nail bed for months. So sometimes patients complain, I took it for 3 months, it started to work, and now I want it again, and finish it off thinking like you normally would with an antibiotic. We got it on the run, let's kill it. There is some hepatotoxicity. So you have to do liver function test, and you just do 1 treatment per year usually. So when a patient calls up to the VA and says, I need a renewal of my lisinopril, I go, sure, I check the potassium and the creatinine. And they say, I need a renewal of my terbinafine, I look, you already got 3 months. They go, yeah, well, I need more. I go, talk to your doctor next time you see him. We usually don't do that more than once a year just because of the possible hepatotoxicity. But other than that, pretty well tolerated. A fantastic drug. We had soldiers, when this drug first came out, most of them passed away now, World War II soldiers that fought in the South Pacific that had the worst looking nails I've ever seen. And these drugs would totally clear it up. So the last one here is the caspofungin. It inhibits the formation of a glucan in the cell wall. Used for candida infections, systemic candida infections, just a whole lot less toxic than amphotericin B. So this next page is your information only, you guys. I mean, this would be hideous. But let's look at the various infections. Aspergillosis, blastomycosis, candidiasis, coccidiomycosis. Notice how amphotericin B keeps coming up here. It seems to always be in the mix. Even though it's toxic, we would much rather use the voriconazole or the fluconazole or the itraconazole when we can. But quite often, golly, cryptococcus, histoplasmosis that's disseminated and rapidly progressing, we just go straight to amphotericin B. So really the main point that I want to make in that chart there is we certainly don't want to memorize it, but just notice the broad spectrum. It has a broad indication. It's a better way to say it. Nothing still matches the utility of amphotericin B. We just go with other things that are much less toxic. Let's see, for candidiasis, we can go oral. A fluconazole tablet, one dose can treat a vaginal yeast infection. I'm just not going to. See, for your information only page, guys. It just gets too. There's too many drugs we can use in place of one or another, but just keep in mind the broad use of the amphotericin B and how the other drugs work, the fluconazole and the voriconazole. So let's stop there, and I'll see you guys next week, and we should have a pretty easy week next week to finish this up. So, take care, guys. Catch you later.